Thanks very much, Ian. Thank you very much for inviting me here today. I joined the Scottish Local Ocular Oncology Service about 2 years ago, and it's been a time of radical change, progressive thinking, and working towards clinical excellence. I'm no expert at this at all, not a basic sciences expert, but I was only coming in here for a few hours, and I wasn't going to miss any opportunity to be able to interact with all of you. So what I'm going to do is I'm going to touch on a few themes: facts, science, and opinion, because there's a lot of that as well in this room. So you've probably seen these slides before. We are looking at probably a cancer case diagnosed every 2 minutes in the UK, so about 1,000 every day. The common ones, the big four, are breast, prostate, lung, and bowel. They make up more than 50% of all the cancers diagnosed. And then when you look at the list of the 20 most common cancers, eye cancers don't figure anywhere. Of course, we knew that. We knew it was a rare cancer, but even I was surprised that in the top 20 cancers, there's no mention of any of the eye cancers. I only wanted to put this slide on because I was struck by this, the fact that cancer survival in the UK has doubled in the last few decades. And as we've heard before, there's plenty of encouraging news, trials all the time, and that pace, that increase is only going to be accelerated in the future. So there's lots of hope out there. The eye cancer cases, this figure here gives you a figure of 738 in 2015. Sachin previously mentioned about 600 uveal melanomas. I would say probably between 500 to 600 uveal melanomas. That figure obviously includes all the other eye cancers that are even rarer. And that equates to, we talk about 6 per million. My feeling is, and again, we're going to look at the figures really closely, probably more towards 6, 7, rather than less than 6. So what about the size? Well, that's your healthy cell. And this represents the smallest possible functional unit of our existence, not just us, but all living beings. And depending on where that cell is in your body, it has a specialized function. It'll grow, it'll replicate. If there's a damage, an injury, a trauma, it will repair the body organs. And this is controlled by two main things: your genetic material, DNA, RNA, and your immune system. And the types of cells we're all familiar with, they're everywhere in your body. If it's muscle, skeletal muscle, smooth muscles such as your bowel, the heart muscle, whether it's the blood or the bone, nerves, each cell is specialized in what it does and how it replicates and how it repairs the organs. So with normal tissue balance, what you've got is this cell replicating until it reaches a point where it knows that it needs to create that balance, which means that one of the cells, and I'm sorry it's coming out poorly here. I've been told there'll be a change of fonts and stuff with the change in computer. One of these cells, which gets damaged, then dies. There is no attempt to repair that. And this process where this cell commits suicide, if you speak, is called apoptosis. Now, this creates the normal cell balance. Cells are replicating, they're dying off, and there's no attempt to repair them. What can happen is that this cell may fail to kill itself. In other words, apoptosis fails. So that's your normal cell growth, and that's how cancer comes about. If this apoptosis fails, then the cells that need to die in order to create the normal tissue balance will not die, will slowly replicate, increase in mass, and give rise to this uncontrolled growth, resulting in a tumor. So, for example, let's look at the skin. I've chosen the skin because it's relatively easier to understand. That's a cross-section of the skin. That's the outside, the outer surface, and that's the epidermis, which is the outer layer of the skin, and then there is the dermis, which is where all the nerves and the blood vessels, all of them reside in the dermis. At the base of the epidermis is what we call the basal layer. And what's happening in the skin is these cells in the basal layer, they are dividing. They divide into two cells. One cell stays in here. The other cell moves into the epidermis. And once it gets to a point where it reaches the surface, it's a dead cell and it gets shed off. So that's how your skin works, and the skin is fine and maintained. What will happen in a skin cancer is this balance will go. So the cell in the basal layer, it divides into two cells, but now both these cells have the potential to divide. So it's no longer a question of, oh, I stay here, I'll be the one who'll be dividing, and you can just slowly make your way to the top. Both the cells are dividing. So if both the cells are dividing, then quite obviously they're going to start to collect and they're going to start to look different from the adjoining cells. Gradually, this will increase in number. The normal organization of that tissue gets disrupted, and you end up with this tumor. And depending on what cells they are and which way they're going, they're either going to invade towards the dermis, or they're just going to form a little lump on the surface. And a tumor is just that uncontrolled mass of cells. So when we use the term tumor for you, we don't always mean that it's a malignant tumor. You could have a benign tumor, which is a mass of cells, which is slow growing, produces a mass effect. You may or may not have come across patients who have these masses that would compress on the eye and cause problems, but don't invade the eye. On the other hand, you've got a malignant tumor, which rapidly grows. The hallmarks of that malignant tumor is the ability to invade and the ability to spread. And that's how, as clinicians, we would differentiate benign and malignant tumors. Other examples of benign tumors, for example, would be lipomas, so little sort of lumps of benign tumors of fat that you may have somewhere in the body, which your doctor says, oh, well, if it's not bothering you, just leave it alone. So why are these tumors harmful? Well, I said, whether benign or malignant, one of the problems they do is cause a mass effect. So locally, wherever they are, depending on what structures they are close to, they'll cause a mass effect. Apart from that, they can then inhibit the function of the normal cells. We saw in that skin slide how that tumor had replaced so many of those normal cells, which means the function of the normal cells is going to get compromised. And finally, the cancer cells can release these substances that can cause all sorts of problems with function and illnesses. And eventually, the tumor mass comes to that extent where it starts to affect all the body functions, whether it's waste disposal, whether it's muscle function. And remember, there's muscles everywhere, skeletal muscle, smooth muscle, cardiac muscle, whether it's brain function or nervous system. Depending on what the tumor is doing, it will overwhelm the body's ability to normally function. So how are these cancer cells created? Well, they're created by what we call mutations in genes. So let's look at that. Well, we're all familiar with chromosomes. We're certainly familiar with X and Y. We've got lots of 23 pairs of chromosomes. And the DNA is this helical structure that is packaged in the chromosome. And this DNA is made up of units known as genes. And these genes are coded by what we call chemical bases. So there's 4 of them. If you look at that, there's C, A, G, and T in different combinations. And they're like letters in a word. You can sort of put them in whatever way, and they will then create an instruction which will be different. In other words, a word that means something different. What happens with a mutation is that it's like a typo. In that word, there is a typo. Either one of the chemical bases changes into something else, or there is an addition of chemical bases, or a deletion. Whatever happens, that code changes, and therefore that instruction changes, and that's where the problems start. And what are the genes that we talk about when we talk about cancer? Well, 3 specific genes. Oncogenes. Now, oncogenes are, it's like a stuck gas pedal. The oncogene, once it's activated, will essentially stop all control and allow those cells to proliferate, because that gas pedal is stuck and the cells have absolutely no control over their replication. The second type of gene is the tumor suppressor gene. that's the brake. That's like your speed camera. It keeps everything in check. But when there is a mutation in the tumor suppressor gene, that natural check mechanism is disrupted. And then the cancer starts. And finally, you've got your DNA repair gene. So if the DNA becomes faulty, if there's a problem, there is this gene that will be responsible for a natural repair mechanism. However, if there's a mutation in there, then again, it cannot repair, and therefore uncontrolled growth. In other words, cancer starts. And that's the result. The cells have no control over their growth. They will replicate into the tissues and result in the tumor. And what causes these mutations? Well, we're all very aware of the risk factors for cancer. And essentially, what most of these risk factors are doing are causing a mutation. So whether it's a chemical, whether it's a virus like human papilloma virus, whether it's radiation, the ultraviolet radiation we all talk about causing skin cancers, whether there's a hereditary element to causing the mutations, diet, hormones, whatever factor there may be, essentially it's resulting in a mutation which ends up being a cancer. And finally, what about the immune system? We've talked a little bit earlier this morning about the immune system. And the immune system, just the way it can fight disease in your body, has the ability to fight the cancer cell. And the way the tumor overcomes the immune system is either the tumor load just becomes so large that it tips the balance, or it finds some way to evade the immune system. Because that's why a healthy person with a perfectly healthy immune system can still get a metastasis, because the tumor can learn to evade. But if you don't have a healthy immune system, then it's more likely to be able to just take the simple path and overwhelm the immune system. Okay, the eye melanoma. Well, I think you've heard a lot about eye melanoma, so I'm just going to put 2 or 3 slides here and we'll move on. Eye melanoma or melanoma comes from this cell called the melanocyte. So whatever we've heard about in terms of what's happening and why there's a cancer, all that happens to this type of cell. Now that can happen on the skin, and that can result in skin melanoma just as anywhere else. It can result in the eyelid. It can happen on the surface of the eye, the white of the eye. Mandeep, I caught the fag end of his talk, and he was talking about conjunctival melanomas. Or it can affect the pigment that lies at the back of your eye, or in that layer called the uvea. And the uvea is the colored bit of the eye in front, the iris, a bit that's hidden called the ciliary body, and the choroid which lines the back of the eye. So these 3 parts together form the uvea. They all have the melanocyte, and that's responsible for the intraocular melanoma or uveal melanoma. Again, you're very familiar about this. The eyelid melanoma is a skin melanoma. This is where UV light is important. Ultraviolet exposure is a risk factor. I think they talk about 10% of these patients may have a family history, and this is probably the only eye melanoma where that is evidence-based in terms of being relevant. This may spread to both the lymph nodes, those little sort of nodes that drain what is known as lymph from the skin, from the eyelids, and through the bloodstream. And when we talk about eyelid melanoma, the mainstay is surgery. Conjunctival melanoma, well, you've had a whole talk on it. No evidence that this is resulting from exposure to UV light, although logically everybody will think, well, it's the surface of the eye, so surely there must be some link, but we don't have any evidence. It behaves a bit similar to skin melanoma. It can spread to lymph nodes and blood. And again, although the mainstay is surgery, we've got a number of other treatments that help us along dealing with this melanoma. And finally, uveal melanoma, and the only thing I'd say here is very important to know that the uveal melanoma does not drain to the lymph nodes. So you don't get those little lumps that you can get with other melanomas along the area of drainage, for example, the eyelid in this area in front of the ear and along the cheekbone and the neck. That will almost never happen with a uveal melanoma. And its favored mode of spread is through blood. In other words, what we call hematogenous. And of course, we know about the treatments, and the radiation seems to be the mainstay treating uveal melanoma. Okay, prevention of eye cancer. This is just the one slide that I wanted to put up. Again, you're probably very, very aware of this. The advice is to avoid the UV exposure. Wear sunglasses, avoid sunbeds, use sunscreen. We know it's important with skin melanoma, with eyelid melanoma. Whether that has any benefit with conjunctival melanoma or uveal melanoma, we really don't know. There is absolutely nothing to suggest that that is indeed true. But intuitively, one would think, why would you not use basic precautions like these in areas where you have high UV exposure? Doesn't happen very often in Scotland, but you need to be aware about that. The second thing I want to talk about is seeing your optometrist, and I think this is absolutely key. We were talking earlier with Neil, with Mandeep. Scotland has free optometrist visits funded by the government under a contract for all of the population. I think it's under 50, you can go every 2 years, and over 50, you can go every year. And I think though the visits to the optometrists are extremely important because the optometrists have an amazing amount of technology nowadays. And even if the optometrist is lacking in skill, which I'm not saying he is, he's gone through his entire training, but irrespective of experience, most of them have these Optos machines and the big cameras that can photograph the back of the eye, and all they then need to do is look at that image and decide whether there is a lesion or not. And early detection of uveal melanoma, I think, is going to be one of the most important things in improving survival. We were again recently discussing the fact that the mortality from uveal melanoma is lower in Scotland. The paper, we hope to publish it within the next few months, and if that is all borne out to be true, then that is further evidence that a regular optometrist visit will help detect these melanomas or nevi, as we discussed earlier, which have the potential to transform into malignancy. And finally, I don't need to tell you that maintaining a good immune system certainly helps. It's no guarantee, but not smoking, maintaining a good diet, exercise, all of that is going to be in your favor. Okay, that's all the science. But the fact is that cancer is personal. And I've been quite moved just a few hours that I've been here, speaking with people, listening to people talk. And I'd sort of tried to look at this and say, okay, how do my patients react? And of course, there's lots of emotions. And I attended a workshop a few years ago, and I thought I'd put some slides in there, but then I stopped myself because in this room, there are people who have already accepted this, have learned how to cope with it. Most of you are here because of your positive attitude, because you've learned to express your feelings, because you're here to share your stories. So instead of going down that line, I need to understand what my patient feels. In other words, what does cancer mean to me as an oncologist? How can I identify with the patient? And again, can I? I don't think any clinician can ever really put himself or herself in your shoes. So while I can think about all the various things that you may be feeling, I can't truly be in your shoes. So then I looked at the pragmatic aspect of it. What if I had a uveal melanoma? What would I want from my National Health Service? Well, that's something I can put some points on. I would want confidence in my diagnosis and treatment. That's the most logical thing. How does that come about? Well, at the moment, all 4 centres do have a solid multidisciplinary team. In Glasgow, I'm very fortunate that we have the most comprehensive team where ophthalmologists, 2 oncologists, a radiologist, a pathologist, the nursing team, and the trainees, as well as the coordinator. We all sit together every single week and discuss every single new patient, new finding, change in a patient's ocular or systemic status. That would give me confidence. in diagnosis and in treatment. I would want to know whether the best treatments are available to me. And I think, again, we're very fortunate in the UK. I think they are. We've got the Proton Beam Therapy Centre in Clatterbridge, who I have to say do an amazing job. And we know that that's not something that's available to all nations. We know that even people from Australia will come up to Clatterbridge for their proton beam therapy treatments because they don't have a PBT centre there. We've got availability of plaques. And as much as we've talked about no investment, we do have some degree of investment so that the radioactive plaques are available to all of us. And of course, resections such as endoresections, exoresections, enucleations. The entire repertoire of treatments is available to us. So I think I'm happy with that. What about access to biopsy, cytogenetics, prognostication? Again, I won't comment on any other centers because I've not truly been there to see exactly what they do. But in the last year, year and a half, at Glasgow, if a patient is diagnosed with a uveal melanoma, we will discuss the diagnosis, we'll discuss the treatment, we offer them a biopsy unless, unfortunately, the tumor is very large and it's going to be enucleated. We'll offer them a biopsy. If they accept a biopsy, we will then ask them if they would like to know the results of their cytogenetics, whether they want to know their prognosis. If they refuse a biopsy, then we offer them the prognosis based on the AJCC grading, staging, where we know from studies, based on our clinical information, what stage this tumor is at and what is the likelihood of survival at 5 years and 10 years. So that's the way we would approach it in terms of discussing with the patient the prognosis. And again, I think with that sort of a setup, I would be happy with it. I would be happier if the take-up of biopsy was higher. I think we probably need to work on that. The biopsy leaflet is again being done up again. Maybe more time needs to be spent with the patients to tell them exactly what the biopsy means. But we're heading in the right direction. And then it'll be about surveillance. What do I want as a uveal melanoma patient? I think the first question I'm going to ask is to the ocular oncologist. What do you think? What do you think I should have? Fair enough. I think that is probably the most logical start to the approach. And the problem, of course, that we've discussed is that at the moment, we don't have a consensus. Now this, I'm very hopeful after even a few hours, may change, but we look forward to that. But in the absence of consensus, if I ask 3 different people and I get 3 different answers, it's just confusion. It doesn't really point me in the right direction. And finally, I will ask if this will increase my chances of surviving. The surveillance modality, whatever it is that you've chosen, will it increase my chances of surviving? And again, as we've heard today, there is scant evidence for that. Today we've heard some evidence, and I look forward to more, and those are the things that we are working towards. So in my view, you've heard this already, so this slide was planned even before that discussion. Offering surveillance to all patients may not be that practical, and a targeted approach may be required. I won't go into the details. We've had a long discussion, and I have a flight to catch before you fire me with questions after this. But the consensus is probably the most important thing. So that's our way forward. That's what we should all look forward to. Don't wait for a randomized controlled trial, as that gentleman very rightly said. Yes, work towards studies, towards research, but very quickly get a consensus so we can get you the surveillance that you want and deserve. Thank you very much indeed for your attention.